12-month prescriptions came into force in beginning of February this year, and there have been a lot of informal discussions amongst GPs on how to safely prescribe and manage the inevitable patient expectations and complaints. I'm sure that in secondary care, similar issues will need to be navigated. In this podcast, we'll discuss the principles which inform safe prescribing and practical ways to manage patient expectations. Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today we start our series of 4 podcasts on safe prescribing. And I've got 3 other people with me in the studio today. We're very lucky to have Kate Wills from Watankani, our panel law firm. Welcome, Kate.
Thank you.
It's been a while since you've joined us on a podcast.
It has.
So good to have you back.
Glad to be here.
We've also got 2 of my colleagues who I'm sure everybody knows. We've got Dr. Tim Cookson and Lucy Gibbard, who both have worked or are working at MPS and both GPs.
Hi, Sam.
Hi, Sam.
So, yeah, I'm Sam King, and I'm also a GP and an advisor with MPS. So, on 1 February, it became lawful to prescribe 12-month prescriptions, and of course, there's been a lot of discussion about that. So, I really wanted to look into this because, at the very beginning, it's going to be new for everybody, for both patients and clinicians, and I thought it would be really good to discuss that today. Tim, would you mind explaining what the changes are and why they were made?
Indeed. So the government amended the medicines regulations of 1984. It's quite an old kind of act, really, isn't it, when you consider all the changes that have occurred since then in medicine. And these are the reasons for the change as advertised by the government. So this is the government's wording. It's to minimise barriers to access for patients. It will save time and money for patients as they will not need to see their prescriber or pay for a phone prescription every 3 months. Patients won't need to take time off work or school for appointments. There'll be less travel required, which is a great advantage for those who live rurally or who have limited transport options. There is potentially greater flexibility for patients and prescribers, and primary care prescribers will have greater time available to see other patients, which the government hopes will reduce the pressure on secondary care services. So the changes are there's a maximum prescription length extended to 12 months, and that includes oral contraceptives. It will not apply to controlled drugs, so the morphine will remain at the same time limit, and medicines will continue to be dispensed, so the pharmacies will be dispensing at a maximum of 3 monthly. So the script is for 12 months, but the dispensing is 3 monthly.
But I suppose they're not paying for a repeat script fee to a GP.
So if you're paying $30 for a prescription, you're going to save $90. How many coffees is that? That's quite a few.
Quite a few.
Isn't it?
Yeah.
I think that there has been discussion on the GP forum pages about charging for a 12-month prescription, which is obviously not something that we need to consider in this podcast because we don't deal with the business of medicine. But I think that will be an interesting point. It would be interesting to see what practices do in that regard.
Yes, because you may need to think, and we may be talking about this a bit further, a little bit more about the what is required to be sure that a 12-month prescription is safe.
Yes, I think that's a good thing for us to talk about. So this all sounds really wonderful. And for those patients where it's appropriate to receive a 12-month script, there's certainly an advantage. So I want to think about, relieving the pressure on GP appointments in clinics. And currently some clinics have a 3 to 6 week wait for an appointment to see your GP, which is obviously really difficult for patients and probably the clinicians as well. And if GPs do manage to see more of their enrolled patients, it will reduce the number of patients attending EDs in the hospital in general, because we know there was a study published earlier in 2025. It was the findings of a systematic review of studies conducted from 2000 to 2023. And the conclusion from this review showed that higher continuity of care with their GP is associated with reduced mortality, admissions to hospital, and ED visits, which is quite an interesting research finding. And also in the JAMA, there was a research published that says that in the US, every extra 10 GPs per 100,000 population is associated with a 51.5-day increase in life expectancy and up to 1.4% decline in deaths, which is interesting, isn't it? So it'll be interesting to wait and see what the 12-month scripts do to that, whether in fact it does make any impact.
Yeah, I think we've got to be a wee bit careful
You go, Tim.
about those, because these are associations as opposed to cause and effect. And so, you look at that and it may well be that in those states, for example, where there are those extra 10 GPs, it's a much higher demographic, so people are healthy, so that there's a lot of other factors that could influence the life expectancy. So it's positive association, but we just need to be a wee bit cautious about.
But also continuity of care it suggests that you're actually seeing that clinician regularly, and actually if you're only seeing this is going to reduce the number of times you see your GP. Is that actually going to reduce continuity of care? That your GP isn't going to have all those opportunities that they used to have with screening and with other things. So, yeah, I'm not sure if you can extrapolate from reducing medication review visits is necessarily going to improve continuity of care.
Or is it because, many of the people that we're talking about getting regular repeat prescriptions have got long-term conditions which are stable, and therefore they may not be seen more than once a year for those conditions?
Yeah, the thing is, I don't know about you, and look, it will be really interesting to see how things pan out over the next couple of years. But, when we get the repeat script requests where we're not actually seeing the patient, so we're not using an appointment, but generally when you get that request, you go into the notes, you check their renal function, you have a look at when their last appointment was, you actually look and see, oh, did I write a referral for that patient? What's happened about that? Oh, have I chased their bloods? It's actually an opportunity and that you take to actually review everything about that patient. And I think when we're thinking we're going to lose those 3 months opportunities to go into the notes and see what's happening. Because so often you think, oh, yeah, that was done that. And I'd asked for another repeat of that. And that hasn't happened. And so it generates me actually reviewing and checking and making things happen. So I think if we're saying we haven't got those 3 month opportunities anymore, actually we've got to be that much more careful at the 12-month time to say what are going to be the safety nets through this year for this patient if I've no longer got that 3 monthly safety net of checking in.
What you're really saying is that we need to choose the patients carefully that we will provide a 12-month script for. And as you say, Tim, there are some patients where I will say we only need to see you 6 months, and for some patients I'll say annual is fine. And I'm not sure that our decisions around that should change just because we're allowed to prescribe 12 monthly now. Yeah. Does that make sense? It's still a clinical decision, isn't it?
Yeah, just because we're allowed to doesn't mean we have to.
Yeah.
And the other problem is that if patients were coming in for that 3 month review visit for medications, often it was being used for a lot of other things. They'd say, oh, I'm here for my repeat prescriptions, but while I'm here, can I just talk about my arthritis, my other things? And the assumption is, well, that patient will still come in about their arthritis, but often they won't.
No.
They wouldn't have come in if it hadn't been for the
Since I'm coming, I'll bring you my list.
Yeah, since I'm coming, I need to come about my medications. Therefore, here are all the other things that are going on in my life, the other things you need to look at. So the question is, are we going to miss out on all that opportunistic care that we used to do?
Well, the other thing too is that, patients' conditions are dynamic. They're not static. And patients aren't necessarily attuned to, oh, my blood pressure's gone up. They don't feel anything. They just feel normal. So often for a lot of conditions, 12 months is just a little bit too long.
But the other thing, of course, will be patient expectations, because they'll read this stuff, if they do, from the government, 12 months. I'm going to get a 12-month prescription. And when you, Sam, no longer or don't prescribe a 12 months, then that's quite different from their expectation. And we can certainly anticipate that there'll be patients who will complain that their right to a 12-month prescription has been denied them. And so that's going to potentially increase the work that needs to be done.
Yeah, and I think we also look at that the people who get a lot of scripts tend to be the elderly, and so when we're looking at that population, they often do have a lot of things else going on. They often have a lot of things changing reasonably rapidly. Look, there was a BPAC article in 2018 that said that 35% of people over 65 were prescribed 5 or more medications in 2016. So look, and 4% were prescribed 11 or more. So there's an awful lot of people with an awful lot of polypharmacy that in that age group. And as you go older, the prescribing rates go up. And I don't know if that's something that when you're thinking about, is a 12-month script appropriate for this patient? I don't think you should make it solely on age. But it may be something that you think, if this patient is on more than 10 medications,
maybe they should come.
Maybe they should be seeing me. Maybe actually just letting them loose with 10 different medications is actually not such a smart thing to do.
I do understand from a patient's perspective, and when we're talking about elderly patients, depending on which area of New Zealand you're working with the demographics, it is expensive for some patients to come in. So I can understand why they don't want to come in if they don't have to. I mean, even some clinics where they're charging $10 per consult. For some people, that's a lot of money. And you can, and I think as GPs, we understand the pressures on our patients, and we want to help them, don't we? We want to be able to make things easier for them.
Yeah,
it'll be interesting because it does create a pressure, really.
Yep.
Yeah, it's hard to know how much losing that review opportunity with repeat scripts, because I think a lot of clinics weren't actually seeing the patients every 3 months. I think a lot of clinics were actually getting the patient to request a repeat script at 3 months and looking in the notes and having a notes review every 3 months, but not actually seeing the patient. And it will be interesting to see that, lacking that, what that impact will have on care, because I think it's maybe an unintended consequence of this is that there will be people who you saw them at their once a year visit now, and you asked them to do some blood tests, and they were routine screening ones. They weren't ones that you were actually concerned about particularly, but they didn't get done. And then you don't see them for another year, and actually they haven't been done. And then when they do get done later, there's something wrong. And then it goes to the HDC, and the HDC says, "Oh, why didn't you chase those bloods from a year ago?" And it's like, well, I haven't even looked in the notes for the last year. Whereas in the old days, I'd have looked every 3 months. Is that going to be taken into account by our complaint system? That we've just lost a big safety net.
I wonder if how the HDC would view that. Whether they would consider, or the medical council for that matter, whether they would consider that we still need to turn our mind to those patients every 3 months, but with no prompt, with no funding. What do you think, Kate?
I think that, as you mentioned before, just because you can do a 12-month script doesn't mean you should. And at the end of the day, it will be a clinical judgment decision. And the HDC and the council will operate on that basis, and I expect practitioners would be vulnerable if it was perceived that there should have been a review or follow-up of bloods that were ordered and that didn't happen.
The problem is the review of bloods is hard because, I set recalls if it's a blood test where I've seen somebody for a clinical problem and I'm expecting but actually sometimes at the 12-month medication review, they're screening. They're not necessarily one that I'm expecting an abnormal result from, and I'm not necessarily expecting the patient to do it straight away. I say, there's a form at the lab for you, go and get that done. We'll just keep an eye on things. But I don't actually chase those bloods, and maybe other people do. But the thing is, if you chase every single blood test you ever order, you'll be up till midnight. Well,
this comes back to Sam's earlier point that the cost for a 12-month script might actually be significantly higher, because in that situation, to cover yourself, you'll need to set a reminder for yourself in 3 months' time to check to make sure the bloods have been done, and then chase up your patient if they haven't been done. So there'll be extra requirements on a 12-month prescription.
These are considerations. They absolutely are considerations if you want to practice safely for your patient, but also medically-legally to protect yourself. This is probably a good junction, Kate, to talk about the Medical Council's statement on good prescribing, because we are measured by those statements, aren't we? So would you mind just talking a bit about that?
Yes, sure, yep. So as you say, we Council's got these statements. They publish them on the website. It's probably important that practitioners go and look at them because, as Sam just said, you are the Council, the Health Practitioners Disciplinary Tribunal and the HDC will use those statements as a benchmark to judge practitioners' actions. So it's really important to be aware of what is expected. And as mentioned, the most relevant statement here is the one called Good Prescribing Practice. It addresses repeat prescribing specifically, and just reading from that statement, it says, it is important that any system for issuing a repeat of an earlier prescription issued to a patient takes full account of the obligations to prescribe responsibly and safely, and that the doctor who signs the prescription takes responsibility for it. And it's quite prescriptive. So it says, before signing a repeat script, you must be satisfied that procedures are in place to ensure that the patient is issued with the correct prescription. Each prescription is regularly reviewed so that it is not issued for a medicine that is no longer required. The correct dose is prescribed for the particular clinical context. You have appropriate information available so that you can review the appropriateness of the repeat script, and this may include a need to access the patient's clinical records. And you must review all information before completing the prescription and ensure that the patient record is maintained and updated. The guidance goes on to say that patients receiving repeat prescriptions should be assessed in person on a regular basis to ensure that the prescription remains appropriate, adverse effects monitored, and the patient is taking or using their medicines as intended. And ultimately, it is, and the guidance says it's the doctor's discretion as to whether a patient is given a repeat prescription. Decisions not to issue a repeat should be explained to the patient and documented accordingly. It's explicit in the guidance that medicines or treatment must not be prescribed for your own convenience or simply because patients demand them. Critical clinical judgment must be applied. So I don't know how much this guidance will change when these 12-month scripts become possible. We've mentioned before, just because you can, issue a script for 12 months doesn't necessarily mean you should. Ultimately, the Council's position is that at the moment, unless it updates its statement, but at the moment the position is that if you are the doctor signing and issuing the script, you bear responsibility for that treatment. And so it's therefore important that as the prescriber, you understand the patient's condition as well as the treatment prescribed and can appropriately monitor any adverse effects of the medicines should they occur. And this, as we've talked about, could prompt quite onerous obligations to make sure that things remain clinically appropriate at certain times. And also the guidance expects and quite onerous efforts to engage and collaborate and coordinate with other clinicians where a patient's care is shared. And so there's an expectation of proactive communication to obtain a full understanding of the prescribing context to inform if or when a review of the continued suitability of a medication should take place. And you mentioned sort of elderly patients that might be on 10 different medicines and the fact that these might change or be renewed or stopped. And so in that situation, I would think a 12-month break before getting them in to have a discussion would come with a high risk, because you need to be aware of potential interactions of new medications or things like that. So, yes, quite onerous expectations from part of the Council.
And it's actually hard to imagine Council will change those on the basis that suddenly the government allows a 12-month prescription. I think the Council can look at it from a safety point of view, and that doesn't alter. And, it can take situations, say you're a locum filling in on the 5th of February, and you've been asked to sign a for a person's prescription who up until now had been getting 3 months, and the person says, well, I want my 12-month prescription now. You're a locum, you've never seen the patient, even if you trawl through the notes, it puts you in a very vulnerable position, I think, to actually comply with the patient request to make it a 12-month prescription.
I think obviously you're going to have that conversation with the patient. So I think that shouldn't be changed to 12 months unless you've sat down and talked to the patient about it. So I think having a consultation to change the script length would be really a good idea. I think I think we're going to go on to talk about, which medications are safe to do a 12-month script for and which aren't. But I think there are some where it's, if the patient is on a statin, the chances are they're going to be a statin long term. As Kate says, maybe you're going to put them on itraconazole sometime during the year or something else that's going to interact with it, and you're going to have to think about it. And the problem is, if they had a 12-month script that maybe was given to them by somebody else, do you even know they're on it? Because it's gone down the list. If it wasn't put on their long-term medications list and it's fallen off the bottom of the script prescribed in the last 3 months, which is what you see on the screen, you may not even know they're on it. Yes, tricky.
It is tricky.
Prescriber beware.
Yes. So what are other components that will go into the decision making around whether we should do 3, 6 or 9 or 12-month prescriptions? It's not just a policy that you can put in place and say, I don't think you can even say only these medications.
No, I think there are some medications there are some at the moment that I sign the 3-month script and think this is a patient that has been on thyroxine for the last 15 years and we haven't changed the dose for a long time. They're having an annual TSH test. I'm not changing the dose in between that annual test. I can imagine that prescribing a year worth of thyroxine for that patient is a safe thing to do.
I think the main thing is to take the patient in front of you as an individual. Yeah. There's no blanket rule for anything.
That's
it's about the patient in front of me is the one that I need to consider right now. And it's not just about, obviously the medical conditions, the medication itself and the monitoring requirements and all those sorts of things. But it is about you're taking the patient, looking at them in a holistic way. If you think about cognitive function, about health literacy, about how compliant they are with their medication, those things also have to be taken into consideration, I think.
There's also consideration for practices as a whole, because, virtual practices will have a policy on repeat prescribing, but I think all those are going to need to be looked at again in the face of a 12-month prescribing and certainly refined significantly and altered to meet those risks and requirements of a 12-month prescription.
I think as well, you look at the you look at the individual in front of you and you've got to think about the condition as well as the medication,
Yes.
And there are some conditions that do vary and, I'm just aware that we do quite a few coroner's cases where patients have been on SSRIs and there's often questions about, when they were last reviewed. And I can imagine that being a situation where the condition is one which carries some risk with it. Rather, and even if they're stable on the medication, they've still got a condition which you may want to review, So I think that you've got to look. So you don't want your protocol or your practice system just to say these are the medications. You almost need to think, well, what are the conditions that we're worried need more monitoring?
In fact, if you've got a practice policy that says, for example, if you've got a patient with depression on an SSRI, practice policy is that they should be reviewed every 3 months unless there are exceptional circumstances or something like that, which would actually be quite good in terms of meeting the patient complaints about, well, why haven't I got a 12-month prescription? Well, terribly sorry, but look, we've reviewed this and this is our policy that it should be every 3 months.
So you think that practices ought to perhaps put a policy together where they do name specific medications?
It could well be useful. Yep.
You might also want to name specific medications which you don't consider to be, that these are the never, or
the nevers
that we
That's
don't
probably
do.
more
Except,
important. The important thing is to say these must be seen. These patients must be seen.
Yeah.
On 3 monthly or 6 monthly. Yeah. So council suggests that we shouldn't prescribe indiscriminately, excessively, or recklessly. And so how do we know? How do we measure that? How do we know if we're prescribing recklessly? Kate, have you got any thoughts around that or cases that you're aware of?
We do see a few cases in the HPDT, the Health Practitioners Dispute Tribunal, where that involve reckless or excessive prescribing. Obviously, that's the most serious place for a practitioner to land, the HPDT. And to reach a point where their conduct's being considered in that forum has to pass a fairly high seriousness threshold. There must be behaviour which falls seriously short of that which is to be considered acceptable, and not mere inadvertent error, oversight, or carelessness. So there, as I said, there's a number of cases involving excessive and reckless prescribing. Most often they do also involve controlled drugs with a risk of addiction and or misuse. Having regard to the nature of that medication, the prescribing often has resulted in harm or prompted a risk of serious harm to patients. There was one case which was in 2022. It contains almost all of the no-nos that we've been talking about around repeat prescribing. It involved a doctor being found guilty of professional misconduct for prescribing a testosterone compound, Sustanon 250, at a patient's request, with 12 repeats in a short period of time, where there was no clinical indication for its use. There was no physical examination, no proper consideration of this patient's extensive medical history, which included body dysmorphia, bulimia, low testosterone, hypothyroidism, hypergonadism, and a heart condition secondary to bodybuilding activities. There was no contact or attempt to contact the patient's primary physician or other doctors that were already involved in his care, and there was no consideration or discussion of alternatives to the pharmacological intervention or attempts to ensure that the prescription was in the patient's best interests. He simply gave it because the patient asked, it seems. Once prescribed, there was no monitoring of the medication's appropriateness, and the patient was not made aware of the potential side effects of the medication. The prescribing continued even after the doctor was notified by another clinician involved of a suspicion that the medication was being sought for non-therapeutic purposes. So obviously that's that sort of conduct posed a really high risk to the patient, and that risk was considered to be an aggravating factor by the tribunal.
If you made that up as a case, no one would believe you.
No, you wouldn't.
It's the full house of everything.
Everything that could go wrong did.
But it's also a bit of giving the patient what they want isn't necessarily what they should get, you know?
Yeah, our next podcast is going to talk a little bit around that.
Yeah. And I think that excessively thing is, I think we often, do think about how much is safe of a particular medication to have. And I suppose that they're still only getting dispensed every 3 months. So it's not like the patient is going to get a year's supply. But there are some medications that I often think, nortriptyline, amitriptyline, the ones that are kind of unsafe and overdose, that I often think about how much has this patient actually got of this medication, and is it a risk to them, also to people around them, And so I do think you do need to think about that in a 12-month prescription. Maybe some strong topical steroids, you're thinking, do I really want to give this patient 12 months of Dermol, without having had a chance to review, or, so I do think what's considered excessive is based on the individual patient, obviously, but you've got to be aware that it may be excessive for that patient.
Yes, and what would be considered reckless? Obviously, this is the very beginning of 12-month scripts, so we don't know because we haven't had any cases yet, but it will be really interesting. And I think what you said earlier, Tim, prescriber beware, and I think that's probably the bottom line from our podcast, isn't it? That it is prescriber beware, because it does rest upon the prescriber. I wonder too about whether additional responsibilities will be placed on pharmacists, or can be placed on pharmacists to monitor, because the patient will be going in there every 3 months, and whether the expectation is that they will ask them about, shortness of breath and chest pain and all those other things. I don't know.
Well, I think that's an unreasonable expectation of the pharmacy,
Because
personally.
that's not how they're trained.
But equally, if the patient is, being seen by them and they are a health professional, they may be held more responsible than they have been.
Yeah, does that prompt an obligation to contact the GP and say the patient's not looking good?
Yeah.
Yes. I mean, if you've got a good relationship with the chemist next door and that's where most of your patients go, I think that's probably how it would go. But a lot of patients these days come from all over the place.
Yeah.
Yeah. Interesting. Can we just quickly turn our mind to hospital prescribers? We've been talking obviously about primary care, but 12 months prescriptions are open to hospital prescribers as well. And currently, when a patient is discharged after being admitted, patients would often get a 1-month prescription from the doctors at discharge, so it forces them really to go to the GP. Do you have any thoughts around what clinicians in hospitals should do?
Generally speaking, if someone's been sick enough to be in hospital, then it's not an unreasonable thing to think that a review by the GP after a month would be a useful thing for them. And so, I think there'd be risks associated for the patient in not having a review at a month. And in that case, there'd be risks for the specialist if they decided to give a 3-month, well, particularly for a new medication, 1 month. I don't think there's any dispute that a shorter period is correct. But what say the patient says, oh, by the way, while I'm here, can I have my statins for a year? Since I can get them for a year. I think generally speaking, it would be wise for hospital clinicians to resist that and say, look, you're going to see your GP in a month's time. Why don't you get your long-term repeat from them? And they can talk about it with you for whether a 12-month prescription is appropriate.
And for those patients who are going to, say, outpatients and in clinics, they're followed by the specialist maybe once a year, twice a year. Do you think that you would give them any different advice?
Well, that's more like a GP consult, isn't it, for a long-standing condition. Again, if it's serious enough that they need to be seen in hospital, you do wonder about the wisdom of a 12-month prescription. There may be situations where it's appropriate, but
I think the hospital clinicians just have to make the same judgment call that the GPs make, which is that if they're prescribing, they are responsible for the monitoring for that next 12 months. Are they going to be monitoring it? Are they going to be checking that those bloods have been done in 3 months' time? They take that responsibility when they write that script. And so they just need to do it with their eyes open and say, am I in a position where I can make sure that this is a safe thing? Am I going to be doing the monitoring? Am I going to be doing the reviews needed to make sure this is safe for the length of time that I've given the script for?
Mm-hmm. And to be honest, I'm not sure that it would be normal for a cardiologist to be prescribing drugs for the bowel, for example. So I think you have to think about scope of practice as well.
Yes.
Yeah. I think I can foresee quite a few complaints arising for clinics, or at least arguments arising in clinics with patients. And so do any of you have any thoughts about how clinicians might try and avoid complaints in this situation as this process is introduced?
Yeah, I think communicating with their patients at the very beginning is probably the start, is actually to send out an email or a Manage My Health or portal email to everyone saying, look, we're aware the government has changed this system. This means that we are allowed to, in certain circumstances, provide you with a 12-month script. This is not a blanket rule. Just set the ground rule. This is not going to be for everybody. There are some people where it won't be appropriate. If you wish to be considered to have a 12-month script, we suggest you make an appointment to see your GP to see if they can discuss whether that would be appropriate for you. So I would start at the beginning by saying to the patients, this is not for everybody, but if you think it's for you, make an appointment to discuss it with your GP. And so that you don't get that whole flood of people just emailing in saying, please change this to a 12-month script. So I would preempt it with that. And then it's having policies, isn't it? Having a discussion as a group about what you feel is safe. The individual clinician is still going to be responsible, though, so they're going to be making the decision. But it really helps to have something that you can point to saying, our practice has decided that patients in this particular circumstances need this regular review. That's our practice policy, and that's what I'm going to stick to.
So you may add to the email, our practice policy has been amended to account for the 12-month prescriptions. You may want to have a look at that because you may be on a medication for which we will not be prescribing 12 months. And so they've got that ability to see it in advance. Yeah. And that's all to do with managing expectations, isn't it, which is so important.
And I think also actually writing somewhere in your communication that because you are on a 12-month script, this means your GP will not be reviewing your notes over that 12-month period as they would have done in the past. Therefore, it is even more important that you come to see your GP if there are any changes in your condition, any concern, because I think I'm not sure how much patients realised how much work went round behind giving a repeat script and what we actually did. And so I think it would be really important to point out to patients that safety net isn't there anymore. And it's all the more important that you come in. And it would be great to have something in writing so that you send out to all the patients. But also if it comes to the HDC and they say, why weren't you checking in these patients' notes every 3 months? You said, well, we weren't doing repeat scripts. We had told the patients we weren't doing this anymore, and actually we'd asked them to come in. It would be lovely to have that in writing, wouldn't it?
Okay, do you think that would be a helpful factor?
Lawyers love having things in writing. That's what we all should be doing. But I wonder, I was just thinking when you were speaking, Lucy, you mentioned at the beginning, Tim, that if you're about to issue a 12-month script, does that consultation where that is issued become quite a comprehensive discussion with the patient? And I wondered, would you be obligated at that, and I think this probably would be the safest route, to tell patients these are the things you should look out for, or possible,
if X, Y, and Z
these
happen,
conditions are happening, you need to come back and have that documented.
It's a lot of work. You're going to need a 30-minute consult.
Yeah. Is that going to free up consultation time for GP?
I'm not sure.
But I also wonder if that's what practices will end up saying, is that 12-month, because it's only going to be every 12 months now, that visit every 12 months for doing a medication review, it needs to be a 30-minute appointment. Because actually the patients, if they were coming every 3 months with their little bits of list that they'd created over that 3 months, and now they're only coming every 12 months, not only have you got to review all those meds, but they've actually got 12 months worth of all the little bits. So you may find that some practices will say, in order to be prescribed a 12-month script, our policy is that you need a 30-minute appointment, which will be charged appropriately. And that may be the clinic policy, that 12-month scripts get a 30-minute appointment.
I guess it comes down to, if you think that clinically the patient is safe to have a 12-month script, like for the thyroxine or the atorvastatin, then they're not going to need a 30-minute. But I guess I'm wondering whether, if you think they're going to need an extra long 1-year appointment, they probably should be seen sooner. I mean, you don't have to.
That's probably very true.
You don't need a 3. It can't. It's not just 3 months or 12 months. You could give them 4 months. You could give them 6 months. And I think it's just the clinician needs to really use their clinical judgment to decide, this is what I think is safe for you. And if we focus on patient safety, because that's why we're doing this. We're doing this. It's not about, I need more money. That's not what it's about. This is about, I want my patients to be safe. I need to be prescribing safely. That's why we're doing this. And I think if the reasonable patient will hopefully understand that, to say, this is why I'm doing it. And what do you think about for those patients who go, Doc, I don't care if something happens to me in the interim. I won't complain about you. I need the 12-month script because I just can't afford to come any more often than that. What do you think? Can they, is that a get out of jail free card? Kate, you're shaking your head?
I'm shaking my head. I don't think the HDC or the council would consider it a get out of free card.
But I want one.
Yes, it would be nice. At the end of the day, you're responsible for the script. You're responsible for the safety and the inappropriateness of the script. And 12-month scripts are not the patient's right. I think that a clinician would be perfectly justified in saying no, and then if the complaint goes to the HGC about that, provided the clinician could present a sensible, defensible clinical rationale for why they made that decision, I wouldn't expect the HGC would take action.
I think it's the same when a patient wants a particular medication that the doctor thinks there's no indication, I don't think it's appropriate, but the patient's insisting it'll be all right, doc, I'll take responsibility. Because we've had quite a number of those sorts of inquiries and cases as well, where patients so desperately want whatever the medication happens to be, where the doctor is hesitant and thinks actually there's probably no evidence for this, but does it because the patient, whom they've known for a very long time, is begging them. So yeah, similar lines, isn't it? Thank you. I think we've covered quite a lot of ground talking about 12-month scripts. Thank you for listening to this podcast, and I hope it's been helpful. We look forward to catching up with you on our next podcast in the Safe Prescribing series, where we are talking about telehealth and for single-purpose or narrow-purpose clinics. If you like the Medical Protection podcast, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org. Thank you, Tim, Lucy and Kate. I think it's been a really helpful discussion.
Thanks, Sam.
Thank you.
Thank you, Sam.